Katrin. Okay, and Beth.
Here.
All right, back to you, Katie.
Thank you, Ashley. As a reminder, if anyone would like to make a public comment today, please message Ashley in the chat or send a direct message. We reserve time at the end of the meeting. And I wasn't keeping track. Is quorum confirmed?
Short. We're one short, I believe.
Okay. All right, so we'll go ahead and move forward without quorum. So I'll leave it to Director Dolph for updates.
Thanks, Katie. I will be quick. You all are meeting this month before the full commission. That happens to us every once in a while. So the commission will meet this coming Monday, and we will be hearing an update on some school early intervention pilots that we've been able to leverage some funding through our partners at OHA, which are very exciting. And then we will spend the bulk of the time next Monday doing our very first 2026 to 2030 comprehensive plan quarterly update. So that is very exciting, and that will take up most of the commission. Quick updates from the other committees. The recovery committee has been focused on recovery community centers, developing a definition that they're going to start having some community meetings about, and talking about current funding sources for recovery community centers to start to think through what makes sense for those going forward. The primary prevention committee started talking about, they have a concept in a strategy in their part of the plan related to we loosely call the center of excellence. I know that's triggering for some people. A hub, there's a need for some kind of training and technical assistance in that area. So they started to talk about scoping that, and then they will also get an update on the House Bill 3321 primary prevention assessment at their next meeting. Health and safety interventions has kind of worked through some foundational things. That's formerly known as Harm Reduction Committee to change their name. They updated their charter, and they are really focused on naloxone everywhere. So that is very exciting from them. And then OYA meets actually later this afternoon, and I think they're going to start talking about recovery spaces, right? Yes. Okay. I think that's right. Kind of a new concept that they included in their strategies, otherwise known as third spaces. So they're going to start having that conversation as well. On the opioid settlement board, I like to give updates there. The settlement board really finally got to this past month their last tranche of funding for the biennium. It's about $13 million. They are going to be engaging in some kind of request for proposal process. Exactly what that looks like, OHA is putting some stuff together to bring back a framework next month. So at some point in the next probably 6 months or so, there will be kind of a broad call for proposals for the state opioid settlement board funding. So we'll keep everybody updated on that so folks know when that is coming forward. And that's all I have. Thank you.
Thank you, Director Dolph. We appreciate those updates. So next we have a community partner presentation focused on high acuity behavioral health. This work is highly aligned with our committee priorities, particularly as we think about individuals with complex behavioral health needs and system utilization. I'll turn it over to Kat Livingston to walk us through the analysis and strategy. And before, Kat, just a real quick question. Would you prefer questions in the middle of your presentation or afterwards? Up to you on how you would like that to happen.
I'm happy to take questions during.
Okay, great. Thank you.
Great. So, hi everyone. I know some of you. I'm Kat Livingston. Hi, Heather. And hi, Beth. And hi, Allison. There are a lot of people who are very deeply involved in some of this work too that I'll be sharing. But I'm the medical director of HealthShare. I'm also a practicing family physician. I still see patients and prescribe buprenorphine at OHSU Richmond Clinic. But I'm here to share about some of the HealthShare work that we've done in terms of this really awesome data analysis for the past couple of years, and then a portfolio of SUD treatment initiatives that we're doing in the region. And then Mitch also mentioned that you all might be interested in some of our IET data and that this group was engaging a lot about withdrawal management specifically. So I just kind of pulled out some interesting data points about some of our withdrawal management data related to IET. So let me see if I can share. So it's always the question. All right. Did that work? We're good. Okay. Fantastic. I have lost the chat, but we'll figure it out. So raise hands or jump in if people want to just jump in. Okay. So just a quick refresher if HealthShare's complicated structure is not immediately clear to everyone. But HealthShare is the largest CCO in Oregon. We serve about 460,000 Medicaid members, and our health plan is administered through four different health plans. So OHSU, Kaiser Permanente, Providence, and then Care Oregon, which serves as our integrated community network and manages our specialty behavioral health and SUD services. So before I get here, and Allison was super involved with all of this, but essentially about 3 years ago, we convened all of our leaders and we're like, it seems like there's a lot going on in the SUD space and the untreated psychosis space and the homelessness space. And so Allison and a bunch of others all got together and said, all right, what is it that we can do as a Medicaid payer in order to better understand more about this population and what we could do, especially in terms of treatment? And so we gathered together all these brilliant minds and they said, okay, well, first what we can do is we can understand the data and then understand really what is the size and the scale and the scope of issues related to substance use disorder, psychosis, and housing insecurity. So that's what led us to this. And this one slide shows like 3 years of work. But essentially, we defined in collaboration with all these partners a cohort as defined within our Medicaid claims data. And we call it the high acuity behavioral health cohort. And so these are people with claims diagnosis of stimulant use disorder, opioid use disorder, psychosis, or unintentional substance associated overdose. And 9% of all HealthShare adults have one or more of these diagnoses, which is about 27,000 people. And so when we look at the utilization of those 9% of our adult health share members, they account for 39% of all of our medical inpatient admissions. So you all know, but people with substance use disorder end up getting hospitalized a lot more. And our data was really quite compelling that they're accounting for 39% of all of our hospital admissions. So super sick, very costly, possibly not getting the best possible SUD care as part of those inpatient admissions. And they also account for 29% of our total costs. So these data were pretty compelling, and we took them to our board, which has driven a lot of strategies, and Beth is one of the key implementers of a lot of our strategies. So we'll talk about that in a moment. But here's just some more data to dive into. We did look at the overlap. We were hearing a lot that the overlap between stimulant use and psychosis is a particular area that's both challenging for our health systems as well as the housing system. So that's where we're seeing people with, very often can be very difficult to treat, a lot of challenges. Obviously, we don't have the same kind of treatments for stimulant use disorder as opioid use disorder. And sometimes it's really hard to disentangle actual psychosis from drug-induced psychosis. So this overlap was helpful to understand. And then just looking over time, essentially those in the opioid use disorder and psychosis categories have been stable, but we have seen stimulant use disorder increase by about 10% between 2024 and 2025, which is also concerning given the different treatment options that we have or don't have available there. And so here's some of the data that we looked at. We're like, okay, so if you're in one of these cohorts, how does that impact your inpatient utilization? And so now we're looking at medical inpatient admissions, and it's per 1,000 member months. So 5.2 is sort of the average HealthShare adults. If somebody's in this cohort, they're at 23, so like four to five times as high rates of inpatient admission. If they have opioid use disorder, it's a little bit higher. Stimulant use disorder, it's even higher, and we're getting up to the 7 times rate of inpatient medical admission. And then we created a housing insecurity flag. So we said, what do we know from medical claims if somebody has housing insecurity? And that's the purple bars. So the green bars are exactly the same as what you just looked at. And now we have these purple bars that say, all right, we have some indicator that they're housing insecure. It could be homeless. It could be somebody did a screener. It could be a wide range, but essentially doubles or triples your risk of inpatient admission to have any indication of housing insecurity. And then we asked, why are people getting admitted? And the number one answer is sepsis. So they're coming in with sepsis, skin infections. There are other things in here like abdominal pain, but really wound care, sepsis, infections are the leading cause of medical inpatient admissions. And then we asked these same questions about emergency department visits. And here you see the same story. They're basically going to the ER 5 times as much if there's stimulant use disorder or opioid use disorder. So lots of potential opportunities to prevent this kind of utilization, obviously preventing people from needing the ER or needing to be hospitalized. But also, we can also improve the care of these populations in the ER and when they're hospitalized both. And here again, you can see the impact of housing insecurity basically doubles or triples your risk of going to the ER as well. So there's this very clear intersection between substance use disorder and housing insecurity and this potentially preventable utilization and morbidity. We're like, why are they going to the ER? Same thing. It's skin and subcutaneous infections and sepsis. And then here is some death data. So essentially this is an undercount. We're using health share data, not statewide data. But we wanted to understand what mortality looked like. And so if you go to the bottom left corner here, people who are in this cohort have a 4 times higher risk of dying compared to other health share adults. You can see there's some variability by subcohort. I just want to point out too, if you look at the 18 to 29-year-old age group, it's really quite pronounced where they have a 13 times higher risk of death compared to the people not in the cohort. And then for like stimulant use disorder, 20 times risk of death. So pretty concerning. And then here's the same data, but now with a housing insecurity flag. And so what you can see here is that if you have this housing insecurity flag, again, this is through our claims data, the risk of dying is 6.4 times for any of the adults compared to non-cohort adults. And then again, focusing in on this top row for young people, the 18 to 29-year-olds, 25 times risk of death. So just huge opportunities here, as you all know, but like the data are pretty compelling and we hadn't really seen them in this way before. So just huge opportunity for preventing morbidity and mortality, especially in an age-dependent way. Okay, so that's sort of, we did this big analysis. It was very exciting. It's driven a lot of stuff. So I'm going to give you a touch about some other data and I'll share what we've done about it. This is just one slide to give you a teaser. Now, so I gave you some housing insecurity things, but we now have agreements with all 3 of the counties in our region to get actual housing data from HMIS. So we are actively ingesting housing data from at least 2 of our counties, and the third one will be soon. And here are just some key findings from our first look at the Multnomah County HMIS data. So this is partnering housing data and healthcare data and figuring out what we learned. And so what we learned is that people in this cohort, people with stimulant use disorder, opioid use disorder, psychosis, make up almost half the people who are actively homeless. They made up a third of people in rapid rehousing and more than 40% of people in coordinated entry. They're twice as likely, if they're in permanent supportive housing, they're twice as likely to exit to homelessness. We saw stimulant use disorder was very prevalent in this cohort. And then we saw 18 times higher risks of avoidable ED visits among those using emergency shelter. So this has spurred so many conversations with our housing partners about like, where is it that we can bring clinical interventions into these housing spaces, or where can we align the 2 sectors to better meet the needs of these folks who have very clearly high rates of potential preventable utilization and may or may not actually be getting the SUD services that they need. Okay, so that was one slide on very exciting housing data. There aren't a lot of people in the whole nation doing this, so it's super cool. There's a lot more to come. Happy to answer any questions about that. And then I was going to just pivot to the IET question because it sounds like that's what this group, that's an area of focus of this group. So here's just some data. This is our health share data in terms of IET. 46% of folks are in the alcohol category, which is not part of the cohort I've been talking about. 23% in opioid, and then 31% in other drugs and stimulants. And I just wanted to share these kind of data because it sounds like you're kind of focused on different settings. So we did this analysis to figure out like when people are seen at different settings, how well does that mean that they're going to end up with IET, with actually initiation and engagement. And you can see here, red means that they had an index event, but they didn't get initiated, and blue means they did, so they got the right care or the best care. And so in primary care, you can see that 80% of people didn't end up getting initiated despite having an index event. In emergency departments, 86% of people did not get initiated despite having an index event. So those two show pretty significant gaps or opportunities, depending on if you're a glass half full, half empty kind of person, to really try and say, all right, if people are having that first visit in primary care or emergency department, what is it that we can do to really make sure that they're getting initiated and engaged in SUD care? And then it sounds like later this meeting, you all are talking about withdrawal management. So I thought you would find these data fun. But essentially, these are kind of surprising to me a little bit. We had some conversations in our SUD task force, and I'll defer to Allison to weigh in on that if you wish. But for this, we actually don't see very high rates of initiation coming out of withdrawal management. Only 56 or 44% are ending up meeting this IET metric. And we had some conversations about it. It feels like housing is kind of one of the biggest portions of that. But happy, I don't know, Allison, if you want to jump in right there.
I can try. I did want to clarify. So the way this is displayed is the different locations, primary care, ED, inpatient. Is that where the index event occurs?
Yep.
Okay, so it occurs in one of those places, and then they can get the initiation can happen anywhere outside of that. It's just that the index event happens in these environments, right?
Yep.
Yeah. Yeah. I mean, I think I recall the last time we talked about this in that group. That's about, we just restarted doing withdrawal management again. So I'd love to be proven wrong, but historically, that's about what we see in terms of the rate of engagement of sort of really meaningfully moving on to treatment after withdrawal management. I do think there is, there's a phenomenon that is most people, a lot of people seek withdrawal management thinking that is sort of the entirety of their need. You see a similar, now OTPs are better at retaining people, but there is a real sort of, once the urgency of withdrawal subsides, you have this next moment about, and no, really what's next. And so, it's a pretty common place for people, I find, to drop off.
And then OTP, thank you. And then OTPs, here you can see there's 93%. So those are very high numbers that are good to see. But it does vary quite a bit by where people are having their index event. And I've got different substances oh no. All right, well, apparently this is opioids. All right, that's not legible. This one is though, good. We'll talk about stimulants. So here with stimulants, we see it's even worse in primary care. Inpatient kind of gets a free pass. That doesn't actually count. It's just sort of an issue with the metric. But here again, you see the withdrawal management, 71% are essentially getting lost to SUDD care there. And ED, again, you see very low rates as well. And then alcohol, some of these are slightly improved in primary care. 21% are getting initiated in withdrawal management. 39% are getting initiated. There's a lot of opportunity for improvement. So I thought it'd be fun to share some of these IET data and figure out like where people are establishing, what are those resources that are available per setting for each of those subcohorts. So I was going to pivot now from data. Should we ask any questions about data, or I can share with you what we're doing about it? All right, I'll keep moving.
Actually, Kat, can I ask a quick question? Can you remind me, does the IET metric or the treatment initiation, does that include filling a prescription for a medication?
Yeah. So prescriptions count.
Okay, thanks.
I think I'll just make a comment, noting that the matching of the HMIS data and the healthcare data is something we haven't been able to do at the state level. And I know it's something some other CCOs are interested in. I'm assuming you all are kind of spreading the gospel on this to try and get others on board. Like, are your data folks willing to kind of sit down and talk methodology about how you did this and how confident folks feel in the accuracy?
Oh, absolutely. There is one other CCO who's doing a lot of really great work. They're doing EHR and HMIS integration, and so we meet quarterly and share best practices and like learn what each other are doing. I'm not aware of any other CCOs that are doing it, so just the one. I mean, in terms of HMIS, we like these have been contracts that we've been developing in partnership with the counties for years now. You know, we have data use agreements. We're doing lots of member matching that's automated and by hand and manualized and QA'd and in deep partnership with our counties. So yes, we have a ton of learnings. We're happy to share with anybody. And, you know, we've done this now for Multnomah. We've just got our Washington data matched. Clackamas will be coming in the future, but it's been a huge multi-year enterprise. And right now we're developing like our analytic plans for what we're going to look at. We're going to start on permanent supportive housing first and really understand how does this cohort show up? You know, how are they engaged or not engaged? Are they engaging with primary care, substance use disorder care? What are their inpatient visits like? And so we're trying to figure out how much do like medical services help them succeed in housing? And then on the other side of that, how much are housing services helping them succeed in health in terms of health outcomes? But we're delighted to share. This is very exciting work.
Yeah, I have a really quick question. For one, I just wanted to throw out there what you just described sounds like Maslow's hierarchy of needs, right? Where housing is at the bottom. So if, you know, somebody has housing, then how can we like progress up that ladder? Really quick question. I don't know if you mentioned this, but how did you collect or how are you collecting the psychosis data?
So all of this is based on, so all of the claims data, it's all based on our Medicaid claims. So these are any claims with psychosis and, you know, whether schizophrenia, schizoaffective, unspecified psychosis. So we defined with our expert colleagues, like what are the ICD-10 codes that would contribute to those diagnoses. And now we've defined those in our data infrastructure.
Thank you.
All right. And then the health literacy need opportunity. Should we talk about that, or was that a while ago?
Yeah, I mean, I'm happy to ask the question, like, and maybe this is something that's kind of part of your like what you're doing about it, but it strikes me that the example I always like to use, I broke my shoulder when I was in high school, and when I left, there was a like your next appointment is with this person on this date, and you'll be doing that, and like you get a substance use diagnosis, like nothing in my life ever would prepare me for that kind of care adventure, I guess. And so I'm just sort of like thinking, like, how do we let people know what it's like to actually go through the system or what to expect when you're expecting to withdrawal management, I guess, is kind of where my head goes.
Yeah, and it seems like there's so many layers of that. Like, what is it that the patient should expect? What is it that a clinician, you know, making sure that all the clinicians that they're seeing for the first time, is that primary care doc, is that urgent care doc ready to talk about it in a trauma-informed way and actually know the resources or be able to offer treatment on site, you know, or have a MAT team or something like that. So yeah, I think at all those levels, it feels like, you know, everyone needs to be sort of upskilled and informed about what are the possibilities. Okay, so should I go on to what are we doing about it? And I'm really excited to talk more about the HMIS data if anyone wants to do that too. That's a whole different presentation. Okay, so this is a summary of all the things that we did. So I'll walk through each of these. So anyway, we took all of these data and we went to our board and we said, all right, now we've learned a ton. What are we going to do? And so we went back and we convened all of our health system leaders and we said, okay, what should we do? We looked at best practices in our region. We looked at national best practices. We got all of our experts. And so we ended up, our board invested a number of millions of dollars into these programs. And so I'll walk through what the programs are. And one of the major implementers of two of the programs is sitting in this room with us, which is very cool. So starting at the top is medications for opioid use disorder in the emergency department. I think everyone's very familiar with it. What we're trying to actually, Beth, do you want to explain what it is?
Put me on the spot. Yeah, sure. So yes, it's a 2-year project where a team, including myself from OHSU, who are experts in the field of addiction medicine and implementation, are providing assistance to emergency departments in the Portland metro area. Currently, it's Providence, Portland, and Providence, St. Vincent's to increase uptake of medications for opioid use disorder. And we're primarily focusing on buprenorphine, providing a lot of support to medical providers, but also behavioral health staff, nursing, peer support. And yeah, I think that's the gist, but happy to go into more detail if helpful.
So our funding is funding the OHSU Impact Team to provide technical assistance to these other hospitals, and that's two Providence emergency departments and two legacy emergency departments. So the goal is that kind of wherever patients, our members are going within our region, they're getting this evidence-based optimal care that involves buprenorphine prescribing. There's a peer who helps connect them to the outpatient setting. It's all developed into workflows, and Impact has done just a tremendous job. The next one is the addiction consult service in the inpatient setting. Beth, do you want to again be put on the spot for that one?
Yeah, so this is a little bit more focused. It's again an impact team, but providing technical assistance to Legacy Emmanuel to staff up and implement an addiction consult service in the inpatient setting there.
And so our funding goes both to the OHSU Impact Team and to Legacy Emmanuel in order to stand up that full ACS team. And then the next purple one, so these are all the acute care settings, is the BOB program, which is Better Outcomes Through Bridges, which is a Providence program that's in actually all of Providence hospitals, and that involves people. I don't know if there is anyone here from Providence, so I'll keep going. But essentially, it's in all the Providence hospitals and involves peers that include mental health peers, as well as SUD peers, and for people who are high utilizers of the ER, these peers connect with them, the community, and kind of figure out what their needs are. And help them meet them with the goal of providing that support and decreasing unnecessary ED utilization. And so this is funding the BOB model at Prov Milwaukee as well as Prov Willamette Falls. And then these lavender ones, so these are ones we're funding in the community setting. So wound care, we learned that everyone's getting admitted for sepsis and cellulitis and all of these things. And we know, and certainly I know as a practicing physician, that there is not a lot of wound care that's available in the community. I never learned about it in medical school or residency. This is an area of deficit. And so we have a number of different programs. We're funding our county public health in order to have FTE that are providing wound care, like in our harm reduction sites. We have tens of thousands of wound care kits that are going out into the community, including advanced ones for people who need to do a lot more self-management. There's a zine put out by Portland Street Medicine that we're translating into some different languages that really helps patients self-manage their own wounds. So that's trying to get more at a little bit more of the root cause. I mean, it's still tertiary prevention, but it's more root cause stuff of let's actually get people's wounds better treated. We offered a CME event that was very well attended. We're offering layperson training events for CME as well. Well, not for CME, for wound care as well. So that's a whole strategy. And then CHAT, which is Community Health Assess and Treat. So that some of you are nodding. So this is a series of teams. It's in partnership with Portland Fire and Rescue. And so when people call 911 and they have a low acuity issue, the normal ambulance goes out, and then the chat team will also go out. And they kind of arrive on site at the same time. They figure out if that person actually doesn't need to go to the ER and instead maybe needs their social needs met or needs to be connected into services in a different way. And so they're able often to divert people from the ER who don't actually need ER level care. They provide resources, and then they follow up with them over the next days to weeks, which can include things like care management, delivering medications, wound care, providing the things that those people need, which is helpful for decreasing ED visits and getting them connected to the right care. And then the last two things that we've been doing, so Project Nurture, I think everyone knows Project Nurture, maybe, yes, no? Yeah, okay. So anyway, love Project Nurture, integrating maternity and addiction care. And we've got providers in the room, but we are offering centralized supports for Project Nurture, including a community of practice for our peers because we were having tons of peer turnover. So really needed to help support the peers in this model, and then centralized support to enable learning collaboratives and facilitating meetings and steering committees and things like that. And then we're doing data. We're going to have a data analysis of our Project Nurture outcomes, which is very exciting. You can tell I like data. And then finally, all of our housing partnerships. So we have this data sharing agreement with our county housing partners. We're doing case conferencing where we get like the housing folks and the healthcare folks and the addiction and aging and disability folks, social services all in a room together. And they're like, hey, we've got John Doe who has a problem and needs this. And all those people are in a room, and we can literally get people connected to services in 15 minutes, which normally would take tons of phone calls. And so the case conferencing has been super successful. So anyway, this is the portfolio of all the things we've invested in for a couple of years now. We're going to have very robust outcomes. Here are all the outcomes that we're tracking. It's very exciting. Maybe the ones you all most care about: IET, SUD services. We developed sort of a medication possession ratio of like what percentage of the time people have filled their or are taking their methadone or buprenorphine or antipsychotics, so we can track all of that stuff. We'll look at all of their utilization outcomes. And then personally, I put all these things in here, of course, of severe morbidity and death. Mortality is something to track, as well as costs. So these are the things we're hoping to see. We're hoping to see reduced acute care utilization, increased IET, reduced morbidity and mortality, and decreased healthcare costs overall. And then we'll be tracking all these housing data too. That's what I've got to share. Would love to take questions or discuss, dive in anywhere.
Can I ask a little bit about the process for like developing your KPIs in particular? Because one of the things that I know that the ADPC has been really kind of prioritizing is like data-driven both decisions, but also kind of like measurement and sustainability questions. Like I'm curious, like what that process was of deciding, are those all just like national kind of accepted measures, so on and so forth?
So this comes from a lot of very invested people and a lot of data geeks all putting our heads together and really coming up with what we thought was important. So some of these are national standards, and many of them are things that we, got all of our local expert leadership together as like, these are the things that really matter, and so we really wanted to define outcomes that would help us understand like what's going to change what we actually do. So this medication possession ratio, that's something that we developed as a novel metric, because previously, about 5 years ago, we ran an analysis showing that people who have more than 80% of their medications have like really, much better outcomes. And there's a HEDIS measure for antipsychotics that's similar. So there are others, but we have also developed them in our own infrastructure. I think as much as possible, we want to use standard national measures. Some of them I think are more actionable than others. But like all of these are standard ones: readmission rates, high utilizers. For that, we use point-click care, avoidable ED, that's based on the New York algorithm, severe morbidity, that's a homegrown one. Mortality is obviously a national measure, and the cost, that's quite standard. So I would say like this was very thoughtfully developed in concert with all of our regional leaders and through our whole board structure.
Yeah, go ahead, Moxie.
Yes, hello. I'm an addiction medicine physician, and I'm wondering how we can take all of this great data, and I really appreciate the presentation. It was excellent. How could we use that to inform transitions to value-based payment for Medicaid and other types of insurance? Just because fee for service is often not sustainable. Because you can build services and make them available and high quality, but if they don't fill immediately, then they're under threat because of finances. Or you end up having to understaff it, and then people get exhausted and there's turnover in staff. So I wondered if you're working on any value-based payment or know any colleagues throughout the country who are doing that. Thanks.
Yes, we are. So one of the biggest challenges in all of this work, this is a fairly significant financial investment that our board is making, and part of our part of our work is to figure out what the business case is. So to understand what these impacts are on cost and utilization, what it would take to sustain them. And there are not many things that we do in medicine that save money. And some of these things are going to cost more money. Like the addiction consult service is the national best practice. It's recommended by ASAM and it costs money. It's going to need, the best possible way to pay for that is going to be through a case rate. And so then there's this question. Yeah, anyway, so that's one example, the ACS model. Project Nurture is another example. That is, I believe, national best practice care, and it's more expensive. And right now, we currently don't have a sustainable way to pay for that. And so as we're looking towards Medicaid cuts, the state, Medicaid, all of us are trying to tighten our belts, or will have to forcibly because of HR1, and we don't have sustainable payment mechanisms. So that is exactly what we need to figure out. I think there's opportunities for the state to step in, for the legislature potentially to step in to really help us figure out which of these need a different type of value-based payment mechanism to support them. And ACS and Project Nurture stand out to me as two very clear ones that definitely need an alternative payment model because Medicaid can't hold these by themselves. Allison?
I'm curious if Kat, if you can imagine a future state with the CCO where I think you've done a really fantastic job of being of this data was very difficult it took a lot to sort of zero in on what we wanted to measure and to get the data, and the HMIS stuff was amazing. And then designing these initiatives that HealthShare agreed to invest in. Like there's a lot of work that got to this moment. And then there is some meaningful financial investment in it. Can you imagine a future state where should something, you're talking about costly programs, but that are best practice. Can you imagine a future state where HealthShare is doing more than encouraging these models to be adopted and takes sort of uses its leverage as a payer and as a plan to say this becomes the standard, right? Like I often think about the investment that and forgive me, I don't remember where you were when this happened, that HealthShare made in the Wheelhouse Project and put a lot of investment that we were a part of in TA and in helping people sort of upskill, but stopped short of saying, and this is an expectation that you take on this best practice. And so it didn't result in, I think, a particularly meaningful expansion of MOUD that it could have. So I don't mean to be provocative, but I'm just curious, like, can you, I think especially in a time where there is scarcity, it is even more important that we are, I think, quite clear about what gets invested in and what doesn't. So.
Yes. So there are a lot of different ways that we can approach it. We did adopt, and I'll share the website, we call them network standard clinical practice guidelines, where we said these are our not just best practices, but these are standards across our network where everyone within all of the HealthShare members will have access to these things. And the two things that met those criteria so far are the every step model, which may not be familiar to many people in this room, but essentially is a best practice for kids in foster care, where there's like clinics that serve, integrated dental, behavioral, really specializing in foster care, tracking, doing really great quality work. It's a national best practice model. And so our entire network has access to every step. And then we also adopted Project Nurture as a network standard. And so then our assumption as having this as a network guideline is that everybody has to do it. And all of our partners are doing it. And with that, it's also not sustainable with current Medicaid funds. And so there's this tension here is we want this available. We're offering centralized supports. We're doing some investments in it, and we're in a pretty tight budget environment that's going to get increasingly worse over the next few years. And so there's a tension there. I mean, my hope would be that we will have addiction consult service as a network standard. We would have MOUD as a network standard eventually. And we really though need to balance. These things need investment and they need support, and current Medicaid rates are insufficient. And there are going to need to be, I believe, value-based payment models that enable this to be sustainable and bring down federal match.
Thank you.
Here you're off mute, Heather. We have like a couple minutes left of time. Go ahead.
And Kat, this is probably too early, but just to throw it out there, kind of along Allison's line, I mean, you did mention, waiting for legislature to make some decisions around the future and how that impacts. I really appreciate that HealthShare has moved things over into network standards and how that will impact those legislative decisions, your ability as CCOs to craft your network priority on a population health level, which is so cool that you've got all this data. It's just amazing to see how this has turned out. It's really wonderful. And so many opportunities. I agree with you. Like this could really help us focus on the opportunities. Because the other one I saw there was just, we can see what's working well, like OPTs, and then what needs some fussing to get people to be more engaged. So I don't know if there's an answer to that, but I mean, are we going to have to wait for what's going to happen to the benefit to really start making those decisions about at the CCO level about what the priorities can be with the new budget environment? Or I'm hoping this is part of the preparatory work. I don't know. It's a very broad question. Like, what do you think's next? What are we waiting for?
I assume your question is to your colleagues. Is that right?
Yeah. Yeah. I don't know. I guess it's a comment and a question to everybody and you. I mean, I know that we know that, the feds are very focused on this particular population that the data represents, and they will continue to be.
I think it's a really challenging time because we're this came from an area of like really, like trying to do really good clinical medicine outcomes, all of this work. And now we're going into this different time of restrictive costs. And so just trying to figure out where are opportunities, even though Medicaid is being cut a lot, there are opportunities to try and make things as sustainable as possible through Medicaid and bring down federal match as much as we're able to leverage it. And so thinking about there are examples of other states like Maine has a moms program where they're essentially paying for a Project Nurture like model. It's based on Project Nurture, and they're paying for it, through a sustainable statewide rate. So are there opportunities to say, hey, for at least some of these programs, let's figure out what statewide resources might exist, making sure, it's not just urban areas, but also rural areas. But I think there's a lot of opportunity for us to be strategic in this time of narrowing, and even figure out like low-hanging fruit. For example, in my view, SUD peers. Like right now, we have these SUD peers who are working in hospitals and in emergency departments. And for Project Nurture, they're doing essential work. They're part of this model, and they are not sustainable for Medicaid at all. And OHA has indicated interest in shifting this, like the ability to just pay them would help bring sustainability to these features of 3 of our investments. So maybe some things are easy, some things are big. Maybe we could pick off a couple of them and just try and figure out how to leverage Medicaid funds and federal sustainability whenever we can.
Yeah, and the little you hear popping up at different meetings, I agree with you, like that value-based payment for the wraparound peer services with the various types of best practice projects seems to be the way the feds feel comfortable. Seems to be. Everything seems to be at the moment. I agree. Yeah.
I see Katie's chat. I wonder what you all think of the answer to that. Katie, I'm sorry if I mispronounced it.
You got it right. It's Katie.
I mean, it seems like widespread access to MOUD is kind of the number one answer. I mean, it's like ultimately, if we can just get MOUD like everywhere in primary care and emergency departments and all of our SUD settings readily accessible and easily attainable, like that's by far the single most evidence-based answer that we have in all of this. And so that seems like, whatever region you're in, like figuring out how to maximize MOUD anywhere people go seems like a very low-hanging fruit to me.
That's very validating. Thank you.
Could I ask one more question before I realize that we're a little bit over time? But has there been like a single or something hopeful that has kind of led to an increase in those IET measures for any of those like those settings that were lower in those connections to those levels of care? Because I keep thinking I think I was talking to you about this when we were setting up time to talk. Like it's very like I would say obvious or apparent to me that the things that are less like the SUD system but are more like the medical system struggle to enter in. Like clients struggle to find their way to the kind of traditional SUD service, and then vice versa. So anything that shores that up, I think is a good interest to the committee too.
Yeah, I mean, for IET, our opioid data is actually pretty awesome. Like the reason that we're not doing fabulously on IET is because of the non-opioid substances. But for example, OHSU is like sky high in terms of IET performance, for example. But there is variability across our systems, and it's really these other substances, stimulant use disorder, alcohol use disorder, where we're not seeing that kind of success, but we're seeing tons of success in the opioid space. And a lot of that is because we've done huge initiatives for the last decade trying to get primary care to prescribe buprenorphine. I've been prescribing it for 20 years now. Like we have the Harbor program through OHSU, which creates low barrier access to buprenorphine. That's really helped our IET rates quite a bit. So I think there's a lot, but again, it's just getting MOUD everywhere. And then we have a ton of work to do in terms of the alcohol use disorder space, especially.
Well, or if there's, I wasn't catching the time. It sounds like we're close to time. If there aren't any other questions, thank you, Kat. That was incredibly helpful context. I I love the slides and I loved learning about all the data. It's amazing what you guys are putting together, what you put together to present to us. So I am also excited to see if other CCOs can put something like that together and create meaningful progress within their systems as well. So um,
Thanks for inviting me.
yeah, thank you so much. And so, in what we're hearing in that presentation really reinforces the complexity of the populations we're serving, and the need for coordinated system approaches. So with that in mind, I'll turn it over to Mitch to walk us through the EPIS framework and how we can think about implementation more intentionally.
Thanks, Kat. If you want to hang out, you're totally welcome to. I don't ever mind sharing space with you, but if you gotta go, I know you're busy. And yeah. So I want to kind of start a little bit by just borrowing. Actually, there's one thing we have to do before we get going today. I am so sorry to start today. I didn't intend for this to happen, but we had a new member that you all voted on to join us and then got to help explain our speakers programs, which was really cool. Beth, would you be willing and open to introducing yourself? I didn't expect for you to jump both feet in like you did, but it was really cool to do that.
No problem. Yeah. Hi, everyone. I'm happy to be here. I'm Beth Williams. I am a nurse practitioner and on the addiction medicine faculty at OHSU. I work on Impact and also in Harbor, the clinic that Dr. Livingston just mentioned, and also have a hand in a few other spaces. So yeah, just like excited for this opportunity to learn and participate. Thanks.
That might have been the most like timely start I think I've ever seen in a meeting. So, um, and if it's okay, Beth, can I bug you for one more thing? Can I actually have you be a participant in something I wanted to get going, like get this conversation started with? Cool. Uh, Bad news for everybody else, but good news for Beth. Beth, we're going to Hawaii. What's your first question?
Is it raining?
I don't know. What's your next question?
What island?
I don't know. What's your next question?
What do I need to bring?
I don't know. What's your next question?
Oh, do I have to bring my kids?
I don't know. What's your next question?
Really, it just hinges on the weather.
Oh, okay. Do you think we're going to Hawaii?
No.
No, not really. I used to use this metaphor with my clients all the time, and thank you, Beth. I appreciate you. And part of one, I used to use this like little story with people. Sorry, my little robot vacuum that I bought on sale that is very loud is deciding to try to help right now. But I used to use this metaphor with clients all the time when we start to talk about relapse prevention or discharge planning. And part of that was because what would happen, and I worked with teens for a lot of my career, was they would be like, I've got no problem. I'm going to do this. It's going to be perfect, sober for life, all the stuff that I think a lot of us have heard. And some of those things, like some of those people do that perfectly. And what I would kind of use that story to really talk through is like, I believe you, but it's really hard once we start explaining those things to other people, and those plans aren't really so sure. When it's an I don't know, we become a little less clear. And if we can't really mark between like point A and point B, people start to lose faith or trust in us. And sometimes when I've done this, the folks have said like, no, I trust you. If you say we're going, we're going. And like there are some relationships that are like that too. However, the benefit here is it would be kind of wild if your first time I was like surprised you get to go on Hawaii with me and nobody else does. Is that in the budget? No, I'm kidding. But I wanted to, so I've been sort of like racking my brain for how to make sure our plan is more clear to everybody else. And I think one of the things that I've been really trying to think about is and there's no judgment in this statement, but I think like we spent a long time making the plan and we got back to the point of implementing the plan. And it's really hard sometimes to remember that like we already did all of the like that work and now we have to implement the plan just as though our clients do. So in kind of a lot of back and forth with Katie and Bradley, who again, I'm very grateful for having such wonderful co-chairs who can kind of handle my ADHD, like what about this ideas. I would like to present you with the EPIS model. So I'm going to give a little bit of background. This is just a brief introduction in it today. We'll spend more time with it as time goes along. But the nice part is if we use it as a framework, it'll kind of become embedded in our work. And then I'll give you some recommendations for where we can go from here. So EPIS, if you're not familiar, it's something that I became aware of when I used to do substance use evidence-based practice implementation. The thing that's really cool about EPIS kind of compared to like other PDSA cycles, which realistically, if you look at this, it is a plan, do, study, and analyze cycle. The thing that is different from EPIS is it describes this interaction of system and program level efforts and is made to kind of be capable of holding both simultaneously. And for our work in particular, I think this outlines, like if I look at this, this tells me a lot about like what the ADPC structurally is meant to do as we're trying to improve these outcomes, improve a lot of things about the system itself. And the model kind of gives us this ability to kind of identify what bridges over those inner context factors, which is program leadership. My gosh, I am popular today. I don't know if you hear my teams going on, but organizational characteristics, the ways that we'll monitor quality and fidelity, which I think I'm really want to zero in there today to kind of like highlight, which is this is something that the rest of the committee has really talked a lot about wanting to get closer to a place of saying that we have high quality, saying that we have high fidelity of all of our services. To get there, though, without being careful means a lot of administrative burden. So everything that we do, it's butterfly effect, I guess, is the way I would put this. So in the exploration phase, what this really looks like is a system or a service group, research group, or other planners saying, here's what our emerging health needs are. If we kind of think about the health share, this is when they start realizing like, hey, we have this high utilizer group. What else do we need to know about them before we proceed? but really trying to identify what those best practices are, the needs, and then subsequently the decision about whether or not we do adopt them. So if we look at this from the comprehensive planning aspect, we spent an entire year talking to community members, talking with each other, talking with agency partners, figuring out what are the things that we wanted to see happen over the course of the next 5 years or beyond. Then we decided, oh, we'll make a plan. So realistically, where we are today is in this preparation space. I know I'm framing this as an implementation, but know that some of this is linear, some of this is recursive. We're going to find ourselves going through this loop and going back and forth pretty frequently in this, but there's a good reason for it. In the preparation phase, this is when we are identifying the barriers to and facilitators of implementation. So this is to kind of like jump ahead a little bit. We have a goal of doing some provider outreach, provider surveys, and provider assessments. That's the stuff that we're hoping to glean from there. And so that's a pretty good indicator of where we are in this process as well. If we're at a place of needing to assess, that tells us we're in preparation. A lot like it is with our clients too. The implementation phase is when we start go time. So there are a couple things in our plan that are maybe already here. There are a couple things in our plan that are maybe even in a sustainment aspect. That allows us to kind of have a different language depending on the concept itself. And then the fun part about all this is sustainment. Being able to understand, one, as a systems level, are these structures, are these processes, are these supports available to actually make those practices possible so that those evidence-based practices can be delivered, and to be able to figure out, like, can we afford to do this ongoing? And probably more important than I would imagine to everybody on the call, is it working enough to keep around because we had the intended public health benefit at the end of the day? Because if it is just something that like we're proud of but doesn't work, I've had some things in my house that like I know my partner would love if I threw away. So sometimes we have to make those decisions too. So here's why this matters to me though. The community providers, the community members all told us change happens to them, not with them. This is the ability for us to actually help change with them moving forward. This is the thing that enables us to actually actualize that ROS framework that we talked about. That's the thing in the bottom right. To be able to say things like, we want to wrap all of our services around the individual who needs them because we've coordinated them at a government level, at a county government level, at a program provider network level, and ultimately so the family, and then going back to that conversation about the like joke I made about what to expect when you're expecting to go to treatment, so that the individual can understand what they're doing throughout that whole process. And also this gives us an ability to embark on all of these overlapping processes, because as we start to look at our goals, some of these things are going to take, I think, Allison, like a quote that I think about a lot that you said during our MOUD work is, this is something that is 10 years away, but it will be 10 years away if we wait 10 years still too. So like, this is one of those things that enables us to like acknowledge that we have these longer term goals that stack on one another as well. And the thing that I keep thinking, I'm going to go back one slide really quick. This is the thing where like, I think this committee can serve its best utility as serving as a bridging factor of sort of this partnership to say, hey, here's what's happening on the provider level that we need to be addressing and we want to see happen. But in order to move those mountains, here's what's got to happen over here. So basically this means that we'll have a framework of being able to talk to each other. Because the other thing that I've been really thinking a lot about is, and for any of you that have worked on a multidisciplinary team, you'll probably know what I'm talking about better than others, but I used to run a team that had peers on it, doctors on it, counselors on it, nurses on it, and all of us speak a very different language. And all of us on this committee speak a very different language as a result too. So this could serve as a unifying factor. And I'm going to give you a little bit of an explanation for how this might come through. I shared this slide last time we met. This is just a bunch of the short-term goals that were outlined in our plan. What I want to kind of talk through is where we are. So I had mentioned that I already kind of view us as being in a preparation phase for a lot of what our plan is looking like. Here's one example. So we said that we wanted to do an assessment of or we wanted to decide on which universal assessment tools should be used across the state of Oregon. In order for us to do that, we probably need to know what assessment tools are being used across the state of Oregon. And I think all of us collectively can come up with a list of the ones that we think we should use, the things that we have used, but not all of us have worked in all of the programs collectively that have ever existed in the state or currently exist. So there's a need for information. However, in order to get there, we have to recommend those, we have to issue that brief, but then the question is, and then what? So the nice part about this assessment also gives us the ability to say, hey, providers, we want to know what you're using, but also if there was like a universal ask for these, like what supports would you need? What would you need for implementation, for ongoing maintenance of those things? What is important to you about them? Do they need to be low cost, no cost? Can they be expensive? Do you need to have funding for those things? These are all the things that we are kind of accountable to be asking before we make an ask of any agency partner or make a policy brief. Because if we don't, and I'm going to be a little honest, it's a little reckless because we all know what that does to the provider base. And I think you've all been in that space too. So here's a way that this has already kind of been working out. Because one of the things that I know I had said to you all back in January was an early success that we might not see successes further for a little bit because it just happened to work out that way. We were doing the 4002 study since 2024. And one of the recommendations that popped out of that study was that there would be an MOUD attestation form that would be implemented across the state to basically say if somebody entered a treatment program, they would have an opportunity to say, do I, they would be offered an MOUD and have an opportunity to say, I was offered, I've declined it, I've accepted it, the doctor told me no, or the doctor told me yes, and I got it. It's a couple initials, it's a signature, it's not a lot of administrative burden, but it has a high impact potentially. When I started talking to agency partners, there was so little concern about this. They were like, that makes sense. This is great. Like, this is low impact. This reaches all these ideas. And then subsequently, we saw that the treatment court system went, can we borrow that language and start screening our folks too using it? And so this kind of spoke to that, like the importance and also the benefit of being able to understand inner and outer context simultaneously, which is what that work group did. Granted, some of this is a little extraneous where I had like 50 pages devoted to it, but that document has everything that goes in every care type. It has all of those things. We did our homework and we're able to do some cool stuff with it. So this is a way that that can actually pull out. And if you'll notice, like once we get to the implementation of that benefit, where's my little, I know somewhere in here I have a laser pointer, I think. But, oh, there we go. Maybe, yeah. So once we get to the implementation piece to this is where like staff need to be trained on this new form. Leadership need to understand like how are they tracking this? Like, are they creating a data system to track this so that they can report and make decisions on it? The other piece to this from an outer context standpoint is, and this is the stuff that I get to do in the background to support you all, but like license and certification needs to be aware when this kicks on so that they can regulate to these new standards and be able to support and not do this too early, not do this too late. And we have this benefit as like an innovation factor of like OHSU has a console line. So we can do this thing to be like, hey, where can I do this? So there's a lot of benefits to using a model like this. I think that it gives us a shared language. The other thing that it can do, if I'm being completely frank, is I think it gives us an ability to kind of invite each other in to talk about the thing that's at hand. Because I know too often, like, especially for me, I'll like dial in to be like, oh, but what about this service thing? Or what about this training thing? Or what about this data thing? But we're talking about the opposite piece. So it allows us to be like, hey, like, I'll pick on Allison just because her face is right there. But like, Allison, sorry, like, I know you really care about motivational interviewing today, but we're talking about a data system. And I can pull Allison back out of that to the outer context. The other really cool thing that EPIS does do for us is it kind of provides us with a checklist of those factors to address. So if we go here, one of the things that I can do is I can, as your staff, I can say like, okay, have we considered the leadership decisions at a program level that we'll need to be thinking about? Have we considered how all of our organizations are different and what their needs? And so we can kind of work through this list as a checklist for the things that we need to do for our work. So before I share my recommendations where I think we could apply this stuff, I'm going to take off my slides. Does anybody have any like major concerns, thoughts, comments, feedback about the EPIS framework being something that we can kind of root ourselves in for how we implement this beast of a plan that you've created?
I don't have concerns, Mitch. I think it's a good model to test to make sure we're asking the question consistently across all the decisions. So it's good to have a framework. Appreciate it.
I guess Kat took all your questions. No. All right. Just making sure. Okay. So going back to the short-term goals. So there's two options. I want to say like now I'm realizing we have 10 minutes. So maybe not two options, but I guess an option to either continue into next month if we need, or next week looks pretty different. But here would be my recommendations for starting places for the foreseeable future. So under the access of evidence-based practices goals that you've all set, we wanted to have metrics, or we wanted to have near term some sort of assessment for either the number of providers offering MSUD, number of justice court settings offering MSUD, assessment of current levels and gaps of evidence-based practice treatment or tribal-based practice utilization, issue brief published on the recommended suite of assessment tools, and culturally specific and place-based services are reliably available. My recommendation is that the these two things on the left, those just get delegated to the MSUD work group that I'll talk about in a second about what I would like to do there, just for their ongoing body of work that we report to this committee. Part of this is because our OJD partners for the treatment courts are collecting this information. We won't have any like baseline really until the end of the year. And then for number of providers offering MSUD, this could be an opportunity for us to identify ongoing processes. We did all that work for the 4002 study, and so we can just bring that on as an ongoing maintenance for that group. In terms of this assessment, this is something I would recommend the committee holds itself, because we need to understand the current scope of the gap of care that we have. We need to figure out how we're going to assess, and that stuff I would like to have be in your wheelhouse to decide. The issue brief, I would recommend delegating that down to the best practices work groups. Remember, there will be 2 work groups formed underneath this committee. This will enable us to have community participation, agency participation, community partner participation, so we can bring everybody along with us and not do change to them, but do change with them. And then that would allow us the ability to identify how we'll be assessing, how we'll be planning, and how we'll be disseminating that list. Because I think it would be a shame if you all create a really cool, awesome recommended list of tools and nobody ever finds out about it. So I want to be really careful about how we get that out into the public too. The other thing I would really recommend here is this goal of ensuring culturally specific and place-based services are reliably available. I recommend that this is just a cross-cutting thing through both the work group and the committee work itself. So if we're talking withdrawal management, we're talking withdrawal management for culturally specific providers if we can. We're talking about them being available where they need to be, but that's just an ongoing, continual thing for everything we do. Thoughts, concerns about this layer of work, because I'm going to go into each of the kind of 4 sections. Timely access. Oh yeah, by the way, I should mention the star is the thing that I think should be our priority initially. I forgot to mention that's what the star means, is I think that's the thing that like out the gate we start working on. So we could next meeting, not today, next meeting, we can start talking through this assessment and start building the thing together. And that way it'll kind of help me figure out like, do we need to, is it virtual? Am I doing a road show? Like, what is it that I'm doing? I think that gives the ability for us to kind of handle that stuff in the back end. So that's the start. Priority here, common access framework developed. This is going to be a long-term project, I think, but we're talking withdrawal management is the early kind of piece to this anyway, but I recommend the committee holds on to it because this involves data, surveys, and other informational services that promote both the outer and the inner context simultaneously. I would think that we might be able to blend this workflow and the assessment of current levels of gaps together so that we're not like bombarding our provider network with assessments and questions. If we can merge those 2 things, I think we could be it might pay off in the end. Treatment provider survey. I also would agree that the committee could just support this thing, support me in being able to try to figure out with agency partners how best to get that data and do that. I think it's worth saying out loud that wait lists and wait list times are kind of an interesting conundrum, I would argue, for we're not supposed to have wait lists, but we're allowed to have wait lists. We're supposed to manage them a certain way. There's a whole like thing. So this allows me to kind of work and try to get that information and then bring it to you. And then we can work with providers themselves to onboard.
Yep.
Go ahead.
I'm not sure how meaningful that data will be. I'm just going to say it out loud. I don't know what else to say besides that, Mitch. You do a great job and people do a great job on that, but the variability on what's tracked and what's not tracked is beyond immense and not particularly accurate. So
I
if there was other ways we could get to the answer we're looking for or the data we're looking for, that's just all I'm going to say about that. So you don't have to respond. I'm just going to say that out loud.
no. I think it's worth responding to. I'm glad that you're saying it because I actually think first pass through this, this is actually something Tim highlighted for us actually when they were doing this work in New Hampshire. One of the things that he said is when they approach different places for like we did their wait list, they would find that like one program had the wait list, but a program down the street didn't have a wait list, and it was really a referral connection issue. Like I understand like there's going to be a bunch of things the data says. I think it's up to us to interpret, which is why I really want this to live with you all and be able to be this thing that like I as your staff can like go out and hunt for data and bring people to you to talk to. Because I think the data itself is going to be like nobody has a wait list or something. It's going to be a little.
Yeah, I just wouldn't trust any of the data.
True.
I don't know if I could make any decision based on the data.
True. And I think that shows a need for something that we need instead is basically the other piece, right? Yeah. Go ahead, Moxie.
I'm really glad Heather brought that up. I know that all of us have been really looking forward to having the data dashboard, and I think that one thing that sometimes disappears from research on stigmatized populations is the narrative of the patients themselves. And so I was thinking about this when you were presenting at the last meeting, the map of where people can get medications for opioid use disorder. And one challenge with that is that there are some places where you can get it, but if you go there, you'll be required to come in so often for urine testing and counseling that you won't be able to keep up with your job or your duties for your family. And those types of things fall out of the data immediately because it looks like the access is great, but actually it may not be patient-centered and may be an excessive amount of care. So I just wonder if there's probably not resources enough to get qualitative research, but I think having focus groups with patients, finding out when they were discharged from withdrawal management, could somebody get in touch with them and interview them and say, we noticed that you didn't go to see anybody after that, and who would be the appropriate person to reach out like that, because that could feel intrusive, and to find out what their experience was like. Some of my patients have left treatment and it looked like they were being offered all the right meds, but when you talk to them, they say, people made fun of me because I was wearing women's clothing and they were forcing me to use my birth name and I'm transgender. And so there was all this richness that was missed by stats. So I just wonder how to get at that. Thank you.
No, that's part of again, like not to be like this is why I'm here. That's actually another reason that I want the provider assessment to live with this committee, because I think that's the stuff that we're gonna figure out. Like if we just go to the provider score, we're not gonna have access. For some of the committee members who let me know ahead of time that they wouldn't be here, they provided like I had a couple folks who provided some similar statements of like questions about the slides when they saw them. They were like, hey, how can we make sure we're having patients or clients being engaged in this if possible? So I 100% agree with you. And I think as we start to put that together, that's the conversation we should be having. One of the things that I would ask that you delegate to me specifically, there's a list in one of our short-term deliverables is a baseline mapping of where all of our programs are. I already kind of showed you a little bit of work that I'm making towards that in our last meeting. I would just ask that you trust me with that and hold me accountable to deliver on that, and I will bring that back to you. And then as a cross-cutting thing, we had this identify opportunities to improve referral pathways and efficiency. That was this like short-term metric. I would argue that like that's an awesome thing that we could hit. I think a lot of us could just say a bunch of things to do there. I argue that this becomes a cross-cutting thing that we do also that will emphasize no wrong door in every single process of our plan. Any other thoughts about timely access stuff so I can scoot us through these last two so we have time for public comment? I would recommend committee as a priority, rate of programs. Oh, go ahead, Heather.
Oh, sorry. I heard a really good metaphor the other day, and I just wanted to share it about referral and wait lists. That maybe no wrong door is not the right metaphor. Maybe it's a clearly marked door that is the appropriate metaphor.
Hmm.
It gave me pause.
Hmm.
I have been a no wrong doorer for a long time. We've done that for many decades. Anyway, gave me pause. I'm just going to throw that in there on the topic before I forget.
No, that's a fair thing to consider. So I would recommend committee holds on to rate of programs with standard discharge planning. That is just this ongoing thing. Again, I think we can embed that in the the provider survey to figure out what's going on currently with discharges, because I think that we could probably survey the folks on this room who would have a bunch of different ideas for what is or isn't happening. But this is something we can embed in the provider survey. We can identify goals and figure out how we can monitor it. Because I think that's the bigger thing in my head is like roads is one of those things that is probably like one of our biggest like state systems that would show where people are going, but that would require us to be able to trust that data. That would require us to maybe expand that data. So we have to talk about that. I would recommend that you delegate referral protocols and processes to the evidence-based practice work group. Let's let them kind of go wild and figure out like a suite of tools. And remember, work groups, they'll all funnel the work back up to you for approval and your committee members. So you get to work in that space if you want as well. But if we only have an hour and a half once a month with all of you, so it would be impossible for us to get all this done otherwise. Baseline metrics, I think the committee can support this. This is a thing that is a little interesting. So as we work through all of these goals, we might come up with KPIs and metrics just as HealthShare was talking about that they did. The other part about this is because we are a government agency who likes to follow the law, believe that or not, we can only change certain things at certain times. And so this would allow the committee to start to align itself with the schedules of different committees so that we can make recommendations as a body to say, hey, have you thought about introducing this as a metric? So I would ask that this is like an ongoing committee topic, and I will work as your staff member to make sure that when those opportunities are available, they come in front of you. And then the last also is targeted outreach programs to high need populations. This is something that largely our agency partners are doing, kind of like the reentry healthcare presentation you had last month. I want to have the opportunity to bring folks in to keep you apprised of certain things, because in these first 2 years, we're not really building anything new. We are trying to figure out what we need before we start doing those things. So this enables us to kind of stay visible about what's going on. And then last, the quality and accountability area of this. There's a metric set that is drafted for including retention, access, outcomes, patient experience. I think this should be a committee activity. We could try to identify some areas using the provider survey, but we might have to be making recommendations to other agency supported committees when appropriate. So that kind of lives in similar area with that last goal that I just talked about. Number of providers receiving TA and funding. Remember that there is a process that I've already kind of outlined that in August, the evidence-based practice work group will convene. Say, here's what all the data, all the engagement we've done says that we need trainings for the year. I'll bring that information to our regional federal partners and say, hey, here's what we want your training and technical assistance to look like. And then if we have dollars or other agency partners, we can have those conversations. We won't start that work until next year, so there's nothing to measure. So that's also part of why I say we push it to the work group, and then we can design, like, are we saying number of people that are engaged, like the impact of those trainings? We can talk through that. Inventory of existing audits, that's something that I'm starting to compile. I would like to be able to work with you all to kind of figure out what are the areas that you want to focus on. Is there a crosswalk? Is it that you want to know how frequent? I want to know what you need, and then I can start gathering that data with our agency partners. And then last is this insight reports that are shared with providers from roads or APAC data to support their own quality improvement goals. I would ask that this is an area that the committee continues to support. Part of this is because we have to wait for roads implementation to go completely full, and then their technical assistance. This allows me to work with the agency partners also to say hey, can we make some changes in that next small change update, or make some changes in the next large change update, or so on and so forth. So I'm realizing we are almost out of time. Do we have any public comment? Okay. I don't see actually any public members. It's all agency partners. Hello, agency partners and committee members. Any thoughts or concerns about those recommendations? And then I'll make sure I email the rest of the committee so that they can respond in kind before our next meeting too. Okay. What I have prepared, I have one more slide that I would like to show you before I let you run away and go get some sunshine, I hope. What I would ask is you to hold me accountable to these things. So assuming I don't get any like wild emails, I'll extend this just a tiny bit so committee members can respond via email. But I would like to get solicitations for the work group sent out within 7 days from today, so we can start getting those moving and scheduling. And then 30 days from that being sent, I want to have those things scheduled. Doesn't mean that they'll meet before the next committee, but I want to have those things be things that I'm accountable for getting progress shown there. Is there any concern for me moving on those two? And then, yeah, what I would like to say then is next month when we come back, we can start all those priority star areas. I will bring discussion stuff and we can start building the dang thing. So that's all I have for you. It's back to you, Katie.
Well, thanks, Mitch. I agree with Heather. That was a lot of work. So thank you for putting that all together for us. And if that's all, thank you everybody for your time today and for the work you continue to bring to this committee. And we'll see you next month.